Hello, my name is Tim Martindale and welcome to part 4 of my series on better understanding of the respiratory system and how it affects the body. I want to expand on the whole concept of what I talked about in the last presentation on the relationship between ventilation and perfusion. In the body, the heart and the lungs have an intimate relationship with each other. If you have heart disease, that can affect the lungs and the body. But if you have lung disease, that can also affect the heart and the body, the other organs of the body. There has to be a good working relationship between the two systems. A lot of the gas laws, gas physics, mimic the heart and the flow of blood. They're equal to each other, or they're supposed to be. So as an example, if you look at ventilation, the movement of air into and out of the lungs, and specifically the clearance of CO2, that is defined as ventilation, and the heart, the two systems from a mathematical standpoint have the same equations of function. For instance, with the ventilation system, the lungs, your minute volume, which is how much air you're breathing into and out of the lungs, is the product of your tidal volume, how deep you breathe, times the respiratory rate, how fast you breathe. This exact same equation applies to your heart and the cardiac system. Your cardiac output is the product of stroke volume, how much blood is pumped each time it beats, times the heart rate, the speed at which it beats. The body's normal compensatory mechanism will always be that your minute volume is affected first by your respiratory rate. Your cardiac output is affected first by your heart rate. So if you have a low cardiac output state, you will always notice that these patients have a higher heart rate. Same thing with the respiratory system. If there's a problem with ventilation, your body will always have an increase in respiratory rate before a change in tidal volume, and with your heart before there's a change in stroke volume. By definition, heart rate is called a chronotropic effect. In other words, the rate of how fast your heart beats. Stroke volume is an inotropic effect, how deeply and how forcefully the heart pumps each time it beats. So let's look at these two systems and what things can alter your ventilation perfusion equality. We talked about diffusion defects. In other words, if I have inflammation of the alveolar wall, or if I have a lot of edema or debris on the inside of the interstitial space, or if I have some sort of thickening of the capillary wall, all of those will affect the ability to diffuse oxygen into the bloodstream through the red blood cell wall, actually to load onto the hemoglobin. And while that is going on, the inability to oxygenate, you're also going to have problems with clearing CO2. This can be changed or treated by increasing the amount of oxygen that a patient is actually breathing. If you increase the amount of oxygen, you're increasing the partial pressure of oxygen inside the alveoli, which will help drive the oxygen by the process of diffusion into the vascular bed. Once oxygen is present, that will help offload CO2 into the alveolar space for exhalation. That is your ventilatory process. The other thing I just want to mention is when we say that somebody is ventilating, what we're talking about, the goal of ventilation is the clearance of CO2. Respiration, by definition, is the exchange of gases. We have external respiration, which is happening at the alveolar capillary network, and we have internal respiration, which is happening at the tissue bed, which is the exact same process, just reversed. We're trying to offload oxygen off of hemoglobin to the tissue bed and gain CO2, a waste product, from the tissue bed into the vasculature so it can go back to the lungs and be exhaled out, to be ventilated out. That's a diffusion defect. Now what you'll notice here, I've drawn, this is the normal relationship. As I'm standing here, as you're sitting there, we're not utilizing all of our ventilatory capacity. We're not utilizing all of the ability of pulmonary circulation because we're at rest. But if we were to increase our activity, increase stress, once we have greater need for oxygen at the tissue level, there's a feedback mechanism which will start to make us breathe faster, maybe breathe deeper, for our heart rate to go up, maybe our stroke volume to increase. As an example, from sitting and being at rest to, let's say we're going to get up and we're going to start to run. We're running down the sidewalk, down the street, at a track, and because of the greater need for oxygen at the tissue level for metabolism to take place, to make our muscles work more effectively, we will notice that our respiratory rate starts to go up, our heart rate starts to go up. If we then change from just a simple run to a sprint, all out as fast as you can, then at that point you're going to notice not only the increase in respiratory rate, but the increase in tidal volume, how much you're breathing, and the same thing with your cardiac system, how fast the heart rate is beating and what is happening with that stroke volume. Because we're always supposed to maintain an equal relationship. For every amount of ventilation, there should be an equal amount of perfusion. Ventilation, perfusion. We will start to utilize greater lung capacity at high levels of stress and activity, just like we're going to incorporate greater amount of blood vessels for the alveoli that will have better perfusion to always maintain a one-to-one relationship. Disease occurs when we've altered those. As an example, a dead space effect is where we have very good ventilation, maybe even overventilation, with poor perfusion. Let's say that a good example would be maybe a patient that has a pulmonary embolus, or they're showering microemboli. What's happening is you're disrupting the ability to perfuse past a well-ventilated alveoli. You can get oxygen into the alveoli, but it's not going to be able to gain access to your vascular bed in the pulmonary system because of a disease process or a blockage in the perfusion. The opposite effect of that would be a shunt effect. A shunt effect is where you have good perfusion, but you have poor ventilation. Maybe the patient has atelectasis. Maybe they have pulmonary edema. There's fluid in the alveoli. Maybe they have a pneumonia, which is a parenchymal disease, which is causing inflammation of the alveolar wall. Anything that affects the ability to get oxygen here. The perfusion is fine, but what's happening is you're shunting blood from the right side of the heart to the left side of the heart without engaging in appropriate gas exchange. That will affect the tissues, because if you can't get oxygen into the bloodstream, which is defined as hypoxemia, low level of oxygen in the blood, that will affect the tissue bed, because now you will have tissue hypoxia, because if there's not enough oxygen in the bloodstream, you can't offload any oxygen to the tissue bed, which will cause those tissues, in order to maintain metabolism, through an anaerobic pathway. And the end result of anaerobic pathway is, unfortunately, lactic acidosis. And that can be a high stressor to the body, and it could ultimately lead to death. So diffusion defects can be treated by oxygen. Oxygen alone cannot alter or enhance the problem when you have a shunt effect or a dead space unit. Either of those is ultimately going to be a horrific problem that must be treated by other means than just oxygen alone. If you have any questions about this, please feel free to leave comments, and I'll be more than happy to answer those comments, those questions for you. Thank you very much.